Hey, brother, morning.
Hey, morning, man. How you doing? You good?
Trend.
The data around the world that really showed us that the issue with key populations, especially sex workers, is a huge issue in terms of HIV prevention. Huge new infections are coming from those groups and their clients, and we need to pay more attention into developing strategies that are going to help us
Boss,
achieve.
please, what is the Serena password? I need to check the live stream.
So we also found that from different studies that were carried out here in Rwanda, that's a real life issue with sex workers. And tackling it,
So if I
we need
need
to
to
not
change,
only do
if I need to change the
clinical or
angle because
biomedical
of the fact I
prevention,
don't have
but
ear.
also
You don't-
have to touch
Okay, I
their
can. Since you are
social,
here, you're close to me.
economic,
Yes, I
I'll
can.
let you
So
know.
if I need to change the angle, I do like this.
Yes.
So you shift
I
to
shift to
another.
another camera.
that
You know what?
shape
Take.
And what we found
He knows
was
exactly what
that
to do.
peer-to-peer among youth didn't work, and we need to see how we can institutionalize a program of mentors to youth, because we found that the youth comprehensive knowledge is tending to go low, and then we need to see how we can inflation the strategies targeting the youth and comprehensive knowledge about HIV. So all of those were really few. I can't go in deep of what worth of sciences that was presented yesterday. And encourage everyone to read the book. Now give the floor to the today session chairs and moderators, Dr. Peter Lomba. The floor is yours.
Thank you, Jean-Pierre. Good morning, everybody. Terrific. Over the past couple of days, we've been learning of the truly impressive outcomes achieved here in Rwanda's national HIV response. Without a doubt, one of the most successful national programs on the continent, if not the world. We've heard of the universal coverage on treatment. And for those individuals, we're seeing some of the best treatment outcomes in the world. Retention rates of 90% in virologic suppression. We've seen tremendous progress, and particularly got yesterday about care for key populations, both high risk, both morally sound and epidemiologically smart. And we've also seen
You know, I'm going to tell you a joke. I have a parliamentarian that was so rigid. I entered the Nationalist Control Committee. I never had heard the word procurement. And I was dealing with partners in the civil society who never had that name as well. And I remember we were negotiating the World Bank project, the first we had 30 million. All the words, so I even didn't know that there was World Bank. So it was learning day after, and we still learn. We learn how to do, and somehow we came all together and said, we have this to do, how are we going to do it? So we have invited, we have really created the national, the UJP, the single project management unit in the National Control Commission. We invent the rules, we invent everything. And because we have put the civil society and everybody on board, I remember going to a friend in Beka, Bambu Kigali, saying, no clue that for managing money. You believe it will work? He said, we look at it and say, so that's how we did. And we are ready, we don't know what tomorrow will be, but we are going to still innovate, be flexible, and one target, let's innovate.
Thank you, Honourable Minister. Let's move on to the discussion of some of the guidelines and partners. First, I'm just going to ask one question to past president. Give us a sense of what the USG's role has been in supporting fighting HIV. Second, as president, what are the current trends in funding from PEPFAR government in general, where we're headed? And third, and most importantly,
Can somebody go to the man that is talking? Camera one, you're just standing here. The man is talking, go to him.
How are we going to show support and how can these partnerships continue?
I know, but when somebody is talking by default, you should know that you should zoom in on him.
Thank you, Peter. The honorable panel members you all. As the honorable minister mentioned, the honorable minister of state
Camera six, can you give me the man that is talking?
PEPFAR coming in
Camera 6,
2003, 2004.
Thank you. Focus, please focus.
Locally.
There you
This is presented
Can you pan to your left, camera 6, you can change. Camera 6, pan to your left a bit. Yes, help him. Stop the camera 6.
Global HIV and TB epidemics substantially a leading role in helping to create a global fund. This is fund the global fund. Those resources come from PEPFAR also has a substantial bilateral program in Rwanda. The program in Rwanda has about aggregate about $700 million, more than $700 million since 2003 through this past year. And we've seen across all countries lots of improvement, but Rwanda has been definitely standing out, as we all know, and I think we're all proud for having been affiliated as my colleagues present. And achieving as close as we can get to the path towards
Yes, zoom in. Camera 1.
applaud that effort, and it's been a considerable
Good camera
pride
1.
and effort
Looking good.
to work with the program.
From you, John. Now, camera 5, you can change your shot.
Through
Change
this
your shot,
last
camera 5.
year,
This time you can change your shot.
the data that I have show that in Rwanda we have about 140
Camera 6 is coming to you.
The PEPFAR support to the program is accounting for about 80,000 of those results. Equally, as we look at testing, as we look at PNCCT. So the partnership is definitely well-founded. I think as the program moves forward, Rwanda again stands in a lot of the bilateral
leadership and capacity as it moves towards the operational management of the majority of the clinical program, over 90%. There's a few pieces where we support the RDF. There's a couple of pieces where we also support some of the UNHCR work, work in the free camps. The CDC program. And at the end of this next year, it's envisioned that 100% of what is being supported through the Ministry of Health is with the Ministry of Health. I think that's been very much a cornerstone of the partnership with the Honorable Minister of Health and her roles as she has moved from CNLS and up through into the Ministry of Leadership. Certainly, yes. That's in a way where I see us now. As we move forward, it's the same acknowledgement we started with here, and that the Honorable Minister of State and the Minister of Health have iterated. And a lot of the bilateral for PEPFAR is going down. It's not just in Rwanda. There's an increase over the past couple of years to the contributions of the United States to the Global Fund, which puts that kind of a maintenance function into the Global Fund's multilateral funding. PEPFAR moving forward under the leadership now of Ambassador Burks, who's taken over from Ambassador Gooseby in the last year, is very much focusing on how do we get to epidemiological control. And as I said previously, Rwanda is definitely out in front towards achieving that, where you can see the end of the tunnel. In many countries, we know we can't see the end of the tunnel. And the cornerstones of that become doing the right things in the right places at the right time towards achieving that epidemiological control. And I think some of the keynotes Dr. Mills came out and Dr. Savans on Wednesday pointed at that. What do we need to do here? What do we need to be sure to be able to cover with the HIV funding? With very much an acknowledgement of what the Honorable Minister noted in terms of how the HIV funding has been able to be efficiently used. I'll say even the abundance of it over the last 10 years has been able to be used to build out the infrastructure that allows the successes of the HIV program, but very much applauding and complimenting the leadership of the government of Rwanda and the people of Rwanda with the other health areas that have been able to benefit and that are now also leading in the achievements moving forward on their own shores. What we have to look at now globally is how do we reduce the numbers of infections? If we continue to have the numbers of infections, estimates range, we'll be looking at another $31 billion additionally per year for treatment. And so this is this epidemiological control mandate, direction that Ambassador Burks is leading with. And I think it echoes with my colleagues in the Global Fund and also with my colleagues in the Global Fund. We realize that prevention is the best means towards controlling.
Can I change after 10 seconds?
And that's
After 10
also
seconds, I
acknowledging
change.
the substantial treatment. We'll get through these challenges, but also
I want to come back to that aspect, but let's move on to first. Patrick, same thing, give us just a sense, what's been the global premise in response to date? What are some of the current trends and trajectories? What do we see looking forward in terms of global fund support? And what are the new strategies for supporting sustainability? I'd like also to hear a little bit about the shift towards evidence-based financing and external
First of all, it's great being back in Rwanda since I transitioned from my position as senior fund portfolio manager for Rwanda. I've already been back twice. Dr. Sadan has promised me a passport, but I still haven't seen it. So the Global Fund was started in 2002 as a public-private partnership. It was created as a response to global emergency, as mentioned by the Honourable Minister. At the time, access to prevention, treatment, and care services was essential. And with the creation, pretty astonishing results, I'd say. Today, we mobilize and invest around $4 billion every year. And currently, around 7 million people are on treatment supported by finance. Now, in the case of Rwanda, Rwanda has played a very special role for the Global Fund. It has been a pioneer for pretty much any single innovation that we have launched as an organization. Whether that is the national strategy applications, rolling continuation channels, you know, the Honourable Minister knows all these different acronyms and terminology. But and of course, Rwanda is also engaged with the Global Fund in other ways. It has been a very active participant on that forward. And the Global Fund has dispersed over $930 million, which makes it one of the largest recipients of financing in the world. And I think the scale of funding is, of course, important, but perhaps more crucial is that it's the leadership that Rwanda has shown. And it has used both external and domestic resources remarkably well. And by doing achieving impact, it was well beyond HIV, TB, malaria. Going back to what the Honourable Minister has said, so maybe to leverage the logical health financing, ensure that the financing results reach everyone.
ndaguma ku mashuri
This
isaha
sort of
yose
partnership is
nyuma y'amasegonda icumi ndagwa sibyo nyuma y'amasegonda icumi kamera ya gatanu sibyo direct unyuze umugozi icyo
guided by our strategy in 2016, we initiated a number of efforts to become a better partner. And I think the most notable change is the new funding model. And the new funding model improves the predictability of funding. It adapts to country cycles. And it refocuses on supporting robust national strategies. Now, the new funding model, every country receives an allocation.
none ngiye gushakira rwose sibyo ngiye gushakira ngo bandika byose amasegonda atandatu cyangwa atanu
window. And this allocation formula is based on the disease burden in the country and population size, essentially. In the past round, has been very successful in the past round system, and with the new country allocation, we're probably likely to decline because the funding that we have globally will have to be sort of distributed globally based on this allocation formula. So the question that I think we started with in the end of last year, together with the leadership in Rwanda, was that we incentivize the same level of results, but with a slight decline of funding. And this sort of thinking led to the results-based finance model that we implemented together with the ministries and the government of Rwanda. Model emerged from a sort of recognition that collectively make both the funds last longer and achieve greater impact by completely aligning global fund finance and systems, by linking global fund disbursements to high-level results such as outcomes and impacts, and by allowing Rwanda much more flexibility in the use of funds where it makes more sense. And this model is really based on a set of core principles that are directly aligned with the 8 effectiveness principles. So if I were to describe this model in very, very simple terms, it all starts with achieving impact. And of course, Rwanda also defines on how to best implement those strategies in world partnership with in-country actors, and also constantly monitors implementation to reallocate the budget where it makes more sense and to respond to climatic needs. Rwanda monitors, evaluates, and reports results, and also audits the implementation through the independent Office of Water General. And globally, we are an active participant. We participate in strategic discussions on national strategies, for example, national strategy reviews. We independently verify the results, and we disperse funds based on the achievement of these high-level national results. So this is not a model that is easily replicated. It's based on the fact that Rwanda's procurement, finance, and monetary systems are very robust, and the strategies are very sound. So we'll probably not see this model being rolled out in a huge number of countries. I think it would serve as a model or an example of what can be achieved under an empowered country program with a line of organized system, mutual accountability, and guided by its own national plan. So in our view, serve as a model to strive for other countries who personally maybe I'm biased because I work very hard on the model, but I'm convinced that this model represents the future. Because in the end, I think strengthening country systems and using those country systems is, of course, key for sustainability. We also have a number of other activities or efforts that we're engaging to increase it's very important for sustainability, but we also from the ability of financing and knowledge for sustainability and plan based on what they expect to see in organizations like the We also have policies to encourage sharing policy and pay policies. And in addition, again, guided by our strategy, we also provide support that goes well beyond our grant fund. And we recently launched what we call an innovation hub to identify innovations with the ultimate aim to develop public goods that would be useful to countries, ultimate work and country systems. And also as part of my new role, I'm looking at other ways to support countries in mobilizing further domestic resources through innovative financing mechanisms.
Thank you. Moving on to the UN funding. Same question, sir. Give us a sense historically of the role of the one UN family in the fight against HIV, your view of the current use of finance, and then finally, what are the UN strategies for supporting sustainability in all countries?
Thank you very much, Ida. Let me also greet my fellow panelists in the series again. I think we have been at the forefront, first of all, in recognizing the pandemic and galvanizing the global community in response to it. And the set of considered since 2000. Development group, but one of them underscored the importance of halting and reversing the pandemic. So the areas that the UN system focuses on the following: leadership, advocacy, coordination, planning, capacity building, treatment and care, research, partnership, and resource mobilization. Now, you might say, all this sounds fluffy, but they are not. Key components of an effective response to any pandemic. And the UN itself has had to reorganize itself to be creation of the UN-AIDS to make sure that the comparative advantage of each of our agencies properly utilized. So the final point is that I would like to say about the UN support, speaking after PEPFAR and the Global Fund, I dare not mention resources. But we have been providing significant amount of resources also globally. Remember that the strength of the UN is technical expertise and mobilization that we bring here. I will end up by citing something I always say to people when they ask me, how much does the UN bring in? I say, you just have to sail along a big river like the Congo River, which I have done. And it's marvelous. You see how the river starts, how it starts. What does it start with? Raindrops in heavily popularized areas. And then as you sail along the river, you see how the small rivers, so this is how we should see the response to pandemics, like HIV, and how we follow. I think the contribution of each and every partner organization is as important as the workers who are doing the privilege, and the bigger. So this is how we see this support. We play a critical role, and we will continue to play a critical role. Now, let me quickly address the issue of sustainability. The UN, you will recall, drew attention to the issue of sustainability 15 years ago at the first United Nations General Assembly special session on the HIV/AIDS. And since then, we have been talking about it. There wasn't much attention initially because resources, even the Honorable Minister has underscored the discordance between needs and also the resources that are available. Paying attention to this. First, for two reasons. First, you will recall that the treatment regimen for HIV/AIDS initially very expensive before the introduction of journalism. Unknown to my colleagues, first time I started working on the HIV/AIDS strategy, dramatically was 2000. It was for the time, like the university, it was very expensive. And then when we looked at the contribution, proportional contribution of the countries compared to it's actually minimum. And we say that this situation cannot continue. There are a few countries like Congo Brazzaville that fund about 97%, but most of the countries have serious resource constraints. So with regard to how we look at the sustainability issue, I will end by just quoting a few recommendations that were made by the UN.
Give your headphone to him.
The first one is to break the upward trajectory of cost through the efficient utilization of resources. The Honorable Minister has said that the one that has $1 and making sure that you get the maximum out of it. The second important recommendation is the addressing of barriers to illegal trade and other low-cost methods. I think the global community has made a lot of progress here. Then improving the efficiency of prevention by targeting interventions to deliver more efficient, innovative, and sustainable programs. Again, this has been done here, but I will reinforce my recommendation. Let us even go further down to target children in school. That will reduce the cost of prevention. We also the synergies, building synergies between HIV/AIDS response and other health facilities. Again, Rwanda is doing this, addressing tuberculosis, addressing NCDs, and so forth. And we are very fast here, don't be impatient. But these are very important recommendations that are still relevant today. And there is the scaling up of new voluntary additional innovative financing mechanisms. And this has started with partnerships with the foundation and now the private sector that Peter is working on that in every way. The young man, we worked together in New York way back. And we were working on the private sector. So that is an important area, voluntary contributions. And finally, is the issue of innovation, adopting as again, the Honorable Minister has made reference to that. Innovative approaches to development, what has made Rwanda what it is. So we have important lessons to go from there. Thank you very much.
Thank you. Honorable Senator Dr. Sanford, coming back to the government perspective, what's the role of the Parliament in creating sustainable response?
Thank you. As you know, the Senate or the Parliament, we are the institution that we are able from we have it's a legal institution. It's not an executive institution. However, for advocacy, we know very well the needs of our community. First, you have as well as possible to increase the budget according to HIV programs. But even if you have to increase the budget, in other hands, you have to make some strategies to reduce new cases of infection in because if you don't have a balance between the budgets and the cases, the new cases of HIVs, it will be not possible. So you need to make some strategies to reduce new cases of infection in HIV in the program. It's our challenges, but it's our targets as parliamentarians. You need to mobilize funds. You need to protect our citizens from the health and sustainability development. But you need, I repeat that, to reduce new cases. Because if you continue to observe the new cases among youth, among citizens, it will be very, very hard. So, as parliamentarians, you have the target to go to the community, to the citizen in the rural areas and urban areas to mobilize our people for the prevention. Thank you.
Thank you, Senator. We started about an hour late. I just want everyone to know we're going to go into 11 o'clock. So we've got about 30 minutes from now for discussion and debate. So please prepare your questions. And I'll be turning it over to co-moderator.
What do you think is the appropriate time scale for that transition to take place? Are we talking about a 2-year, 5-year, 25-year, 200-year process? If anyone wants to respond.
Question. It's very difficult. I'm a trained econometrician and now the humble by actual experience. It's very difficult to make precise. But if we look at what has happened in the past, the in terms of the funding, and then the transition in terms of the effective response to the measures that have been taken in order to meet. First of all, I think 15 years is reasonable. Now, the global community is now galvanized. We are encouraged by the turnaround that has been achieved. So 15 years is, I believe, that is good in terms of the target development itself. When it comes to sustainability issues, it's a combination of what is happening on the supply side, we may do it finance provider side and also on the side of I believe that we might not be absolutely those 5 years or 10 years. It will depend on political action as well. It will depend on the will of the leaders. So that will be very. But I think 10-year periods.
I say in the beginning that I would love to have a crystal ball and see what happens. I think it depends on many things. It's 10 years for who? For which country? For which part of the world? It's 10 years that will depend on the behavior of governments and development partners, as well as the behavior of countries. It can be 10 years if, everybody should remember the Marshall Plan. What happened after the Second World War? The US and others came together and decided that Germany should not be broken. So they decided to put money, exactly what Global Fund tried to do now with us, PEPFAR tried to do with us. They just said, this is the money you need to grow, we give it to you. The only thing is, be accountable, and they were given those accountable, because it was not really requested. But develop your private sector, make money, and out of the taxes, the sector, education, etc. Do that with me, 5 years for one time.
Wow.
If we turn, we have a number of other development partners represented at these tables at the front. Does anybody have any reaction to the other comments that have been made by the panelists? Do we have a
So maybe we can begin with CDC. Where's the CDC?
Good morning. It is apparent that Rwanda has made tremendous accomplishments in the HIV epidemic control. And they are considered a long-term strategy country. Is that they still need support. And in an environment where there is declining budgets, and we still have to, they still need to build capacity. CDC is committed to with support is to coordinate and work with our global partners and the stakeholders in the country to leverage whatever funding is available. And from year to year, we don't know what that is, and that's unfortunate. Our goal is to improve efficiencies by building synergies, collaborations, and trying to ensure that we decrease the duplication of activities across entities. Committed to strengthening and enhancing systems, and we are doing lots of things in Rwanda in terms of trying to use the Rwanda HIV or information systems to data systems to inform and target and evaluate impact that is happening here in Rwanda. One of the local sayings that I have over the years is, how do you get the biggest bang for your buck? And I believe the way to do that is to work together. And we don't always know what the funding levels are going to be, from year to year, but as Chuck said, one of our commitments and one of our marching orders is to focus on doing the right thing at the right time in the right places. One of the current activities that because the capacity is here in terms of clinical services, we have moved funding from international NGOs to the Ministry of Health, and we've transitioned the funding for those clinical sites to the Ministry of Health. And to date, approximately 150 sites have been transitioned under the leadership of the Ministry of Health. And we work along with them, providing technical assistance and support, whatever needs to ensure success. And I think the Ministry of Health is showing much success as we evaluate their impact and outcomes. So, in short, I think what I'd like to say is it's an ongoing partnership, and I don't know, although funds are still needed, I think the best way to work together in a declining budget environment is to partner with all global partners to ensure that we are leveraging what funds exist in the country.
Thank you very much. Please feel free to pass around the table, and if you could introduce yourself and who you're speaking from, who you work for.
Thank you. My name is Jesse Joseph, and I'm here representing USAID's Health Office today. USAID has a long history of supporting the government of Rwanda in HIV, as well as other areas, technical areas of health and health systems generally. Care and treatment, health promotion, socioeconomic impact mitigation, and health systems generally. Along this path, Rwanda has made remarkable achievements in reducing new infections and deaths associated with HIV. So the challenge of sustainable financing in a declining government environment, the approach that our other bilateral and multilateral donors are aligning with. Financing model through the Global Fund is going to take us the extra mile to mutual accountability for results and resources.
Thank you very much. If you could pass the microphone around and see if anyone else wants to.
Thank you very much. I'm Swiss, and would like to start by thanking this very distinguished panel for the discussions and the topic itself that is being discussed. We believe that this is really an opportune time for Rwanda to address the sustainability issue. As I was mentioning earlier, I was saying that we believe that it's an opportune time for Rwanda to be addressing the issues of sustainability of the response, given the successes. And to paraphrase the Minister herself from previous occasions, she's mentioned that a great deal of progress has been made. There have been lots of gains. Those gains are fragile, and we should keep an eye on them consistently. I won't mention the specific organization, but at this point we're really focused to accelerate the remaining scale-up, looking at it as an investment and the use of the investment approaches to the issue of sustainability. And in terms of the work going forward, it would look at the synergies, it would look at technical and financial efficiencies, and look to the issues of innovation. And I don't think that's something new. I think previous speakers have mentioned that as well. And I don't have an answer to the question on the absolute timing. I'm not a health economist, but to my mind, it would be, something that I don't think can be rushed, because then the gains will be compromised. Thank you very much.
Thank you.
Thank you. Thank you very much. My name is Nola Skinner. I am the UNICEF representative here in Rwanda. So it's definitely my obligation to say good morning, Banabeza. Very nice to be here. I just want to make 2 points because our resident coordinator has spoken on behalf of the One UN, so I won't go into details on our programs. But listening to the discussion, for me, what is really fascinating, and I think also the future, is something that the Honourable Minister of Health had spoken about, and I think also Patrick. Looking at the financing of HIV not as a vertical issue, not as a vertical health issue, but actually as an integrated human security. This is looking at the financing and the funding of HIV as a human security issue. The second, I think we need to harness that. The second thing that I want to emphasise is something that the UN Resident Coordinator also spoke of, and the Honourable Minister on the first day, and that is the children and the adolescents. If you want to eliminate mother-to-child transmission, then we need to be working with the future mothers and the future parents now. And that's something that we, as UNICEF, the UN family, and in support of the government, see a really top priority to harness. And we know that the government of Rwanda, with its citizen-centred development, has children of citizen-centred development, and we think this is a future generation. We need to be working with you, and we need to be working with you now, and we are. Thank you very much.
Good morning, Nathan Ford from WHO in Geneva. Thank you to the Ministry of Health for inviting me to this fantastic conference, and thank you to all the panelists for a great session this morning. I'm new to Rwanda, but I know other countries in the region, and one of the pieces of data that I've seen presented in the last couple of days that has really struck me as a fantastic success of this program is the CD4 when people present at clinic, because that is an indicator of how early you're reaching people, how effectively treatment is to be, and how in terms of the coverage of treatment. But it should also be acknowledged as a success story, being able to identify people early, which maximises the chances of having success. Many other programs, including in this region, the median CD4 at start of treatment is around 100. That's a very intensive clinical care program that costs a lot of money, has a higher mortality outcome and a risk of transmission as well, so incidents, onward incidents. So you should be really congratulated for getting people into care early. And that leads me to believe that the current ambitions that the program has in terms of starting treatment immediately for key populations is the WHO guidelines, which, as you know, are expert guideline development committees looking at every couple of years and updating guidelines, currently recommends treating with the CD4 of 500 and giving immediate treatment to certain groups. But we are looking to Rwanda and Rwanda's forthcoming experience of treating immediately key populations, because just as Malawi, for operational and practical and epidemiological reasons, started treating pregnant women immediately irrespective of CD4 and pioneering the option B+ strategy that is now globally recommended by WHO and adopted by most countries. So we will look to Rwanda for its experience of providing treatment immediately for key populations as a way to bring down incidence, and we are learning from you and adopting good practice in global guidance. So all that to say, congratulations so far, and I think your ambitions are the right ones. They're supported by evidence, they're supported by the epidemiology, and they're supported by where the programme currently is in responding to the epidemic. So congratulations and thank you.
Thank you. I just want to, it's good, but it's not something unusual in Rwanda. I just want to say that HIV, TB, malaria, has agriculture, whatever. We have to be evidence-based. And to be evidence-based, we need to read what happened here, what happened elsewhere, to take the experience of colleagues elsewhere. So when we decide something, and I remember when we decide to put women on treatment when they are discovered, except if she refused for some reason, we read what and we decided to go for that. We didn't have 100% support, I have to tell you, because the answer was too expensive for you, too difficult to manage. How are you going to follow it? It's going to be increased like that in your that's what the science told us. That's what we're going to do. So evidence-based is a principle of not only the Ministry of Health, it's across sectors. And even when we go to defend the budget or to explain what we did with the money, I want to say that even the money of PEPFAR, of global fund, we have to go and explain to the parliamentarian what we did with that. Huh? They ask us why, and we better have an answer. So it's a national project.
Thank you very much. I would like to come back to the
to most urgent needs, meaning we have the vaccination, we have children vaccinated for 10 vaccines, etc. We have family planning, we have HIV epidemiology, and domestic revenue. We already take over some of those costs. The last 3 years, we have focused on absorption of the health professional funded by partners. But slowly, and we had this check. They wanted us to take over where we are, and we said no. We want to expand what we have across the country to absorb a bigger percentage. Like if you have 5,000 people paid by partners, we want to pay 5,000 for cover the entire country before taking over the 5,000. So they are after problem. We have to come together and see what we do. I recall here in 2009, kind of fundraising for global fund. We invite private sector across Africa. They came here and we managed to raise $3 million. So there is no one way to do it. There are many ways to do it. Tobacco is going to be taxed also, but for other things, etc. We now, so I can continue, but we have so we are going to create an innovative way for women at rural areas that are not employed to have maternity leave. You see, so we go not necessarily for HIV every time, but we never stop.
Thank you. I may say something also about the sustainability. I know we are already discussing of working on the longer term strategy sustainability beyond the current national strategy for strategic plan for HIV, which is only 5 years. And I know there won't be one solution, it must be a combination of different measures. But I can see some elements of that. One is to, of course, many initiatives are taking place already, especially around the cost savings. And we are already implementing different programs. We used to have separate programs, so now we're trying to integrate some of activities to reduce the cost, like supervision, like evaluation, etc. We are also trying to reduce other operating costs, like seminar training, try to use different technology, distance learning, etc. And also we are in the process of really assessing the staffing issues in that sector and see how can master the wage bill and the size of the staff. Of course, prevention, as was said earlier, prevention is key to reduce the cost of treatment in the future. And targeting the is really important, as was mentioned earlier. But also, we are also trying to improve the managerial capacity of the leaders of health facilities. Now, currently, all administrators of hospitals to keep their capacity to manage hospitals. And also, one area that we focus on is the development of the private sector. We need to discuss a strategy how we can attract the private sector in the health sector. To give an example, it cost us to build and to equip this hospital about $10 million. Just to have the infrastructure, the building and equipment, it's about $10 million. And this is about 10% of global fund support annually. So if we had, for example, 3 investments in hospitals, it would be about 30%. If we add the public, it would be even 40%. So we save money from public investment in facilities and we use it in other priority areas. So we think that during the discussion about that plan, we seriously look at some of the elements of sustainability, but I believe we have more ideas in the course of the development of the sustainability plan.
People say across the world that the achievements in Rwanda have a lot of money. I want to explain this, guys. The last 4 years, even if we have great support, there are more than 50% in that support. 50%. But we have managed to provide more care. So that when you see, in a way, it's difficult to calculate what we do. But we had 50% less money, and we have increased the care. So you can see how we have absorbed, but we have absorbed, as Minister said, by efficiency of doing business. And also by a portion by our national domestic
It seems to me that very many of the building blocks for developing this are ingredients that are necessary, are very well understood and
the representative of UNHCR said it should not go too fast because person to cross the river, if you give it a too long way to go, you know how to swim, you will never make it.
We're about at time. I wonder, Robert, whether we can take at least a couple of questions from the audience, maybe three questions.
Can help me. If we want really to eliminate mother-to-child transmission by 2015, we can use the strategy they used in the US to make elect President Obama door to door. I think many of us knows people are pregnant and stay at home. Of course, all of us have a notion that we need to go to every place to the hospital, but many of us
intensify the collaboration with those people and attempt to provide a better future for the people suffering from HIV. Thank you.
Good morning. My name is Dr. Saladin from UNICEF Young Headquarters. Yesterday, I did make a presentation on focus on investment. And in that presentation, I had 2-3 slides that look into investment education. And I just wanted to bring to the attention of this panel, in terms of what we're discussing, that the investment we have made in the early years of children will result in a very good improvement in the quality of life for children who are living with HIV. And many of them are now becoming adolescents. And as adolescents living with HIV, we need to follow through so that we can guard what we've done. And we have kind of did a modeling using the investment framework with the London School of Hygiene. We were able to show that in the next 5 years, will really avert a lot of deaths in adolescent population living with HIV, and also it will help to bring the adolescent population on track in terms of towards ending HIV infection and towards the end of AIDS by 2030. I'm using this opportunity to teach that as we do resource allocation, both in health and in HIV, this is the time for us to actually deliberately target adolescent population with direct investment on AIDS, because by so doing, we will not only be guiding investment and the result we've achieved, but will help to put towards ending AIDS by 2030. Thanks so much.
Thank you. My name is Jackie Modiambo from Partners in Health, and I think that the biggest lesson we're getting from this conference is the tremendous impact of ART, both in life expectancy and also just enabling more people to get in treatment early. And so goes to Global Fund and PEPFAR presenters. Now with health finance going down, what are some of the new strategies advocacies you're working on in terms of reducing the cost of HIV treatment and making antiretroviral therapy available for Rwanda and other low-income countries? Because we know that most of these treatments are not easily accessible because of international trade laws that limit especially the production and distribution of the treatments from low and middle-income countries. So my question is there any conversation around how to ease in those laws so that we can have more available? Thank you.
Thank you. My name is Monamari Organization, IMRO India. First of all presenters and good ideas how to see out and reduce reinfections with investment, which is not big, but I would like to come to one thing whereby civil society well involved in terms of advocacy, whereby key populations still for the reinfection where the stigma and discrimination continue to surround that target group and continue to hide themselves. So I would like to hear from and the other partners there involved in advocacy how we can reduce that kind of stigma and discrimination surrounding people, especially female sex workers, men with sex with men, whereby we need to increase advocacy. And with them, also the Ministry of Health, where they developed the new strategic plan. This team 2018 is focusing on those target groups, but the implementation also needs all stakeholders to make sure that that new strategic plan is implemented, fully implemented, because we are targeting also those target group. But if you look at data from different presenters, from researchers, they show that 60% of female sex workers are HIV positive. And if you look at the investment, maybe which is investing that target group, or maybe evidence-based show the problem, it's still comparable. So we need to use data from our researchers for the implementation. This was my answer.
So we've got 5 questions to respond to. Perhaps the Minister of Health or another representative from the Ministry. The first was a question about the feasibility of home-based counseling and testing for HIV, particularly among pregnant women. And the second was engagement with traditional practitioners in the fight against HIV.
I think there is even 3 questions Dr. Sadat can have to ask. But I'm not addressed to Dr. Sadat.
Don't fucking waste it.
Thank you very much, Bert, for the question on elimination of multi-type transmission of HIV, which is an important topic, and we aim all of us to reach this very soon. The door-to-door campaign that you referred to, I think we are doing a kind of door-to-door campaign. I would refer, or call it community-based interventions to reach pregnant women earlier for the HIV test, those who are in need of protect their babies. Using some data recently from HMIS and also DHS 2010, we're above 70% of women delivering the facility. I don't because our community health workers are doing this job already. Really kind of door-to-door campaign dealing with this. And there are few we are missing so far. There are many strategies to reach them. The recently, Kaburo, Wakawabe, all that. So this will help really to reach these women earlier. And those who are of them are tested for HIV. These are data from HIV program that we presented. If we are progressing in that line, I'm sure we'll be able to eliminate HIV transmission from mother to child.
So, I think that was the answer. But there was this one antenatal clinic where they are advised to test and come with the and 98% of them, but the nature doesn't have the round numbers, but we better, like Dr. Sabat says, build on who we are, build on what we have created to go forward. And our communities have health workers, one dedicated to pregnant women and children under 3, are the best allies to target pregnant women in their own village. The other question was traditional medicine. So the story of traditional medicine in Rwanda, I don't know where you come from, sir, but in Rwanda is a tragic one. The traditional medicine in Africa are more often linked with spiritual power in Africa, elsewhere also. And let's go back to the colonial time. We were colonized by the Belgians, who delegated the power to the religions. And the religions fight the traditional healers because it was a control to the spiritual power, if they want to really, and the traditional healing. Support education.
Thank you so much, Honorable Minister. It was just a comment that this is the time for us to invest more in adolescents in the context of HIV. Because this has been massive progress in children, and because of their activity, children who are HIV positive are living longer. So what we have to do when we compare to other age groups?
In Rwanda?
No, globally.
Okay, come back in Rwanda.
Now in Rwanda,
because we have created since 10 years 8 clubs that we have transformed 3 years ago in health clubs in all schools. Sure, there is a lot of improvement to do, but we try to do prevention through that area. And also coming programs at village level. But the best thing to do is that on the Rwanda soil today, even if with the spectrum projection of measure evaluation and UNAs, etc., there is nobody who can stand and say, I'm HIV positive, I deserve to be on treatment and benefit. Children as well. We are tracking them when we know that the parents are HIV positive. We try, and now it has passed through the penal code, but no judge has agreed to implement it. If parents are HIV positive and they don't tell, I would love to catch them. But the penal code was voted, but we are not yet there. So we do our best and we progress as we go.
Thank you very much.
So we just have 2 other questions to respond to, and then we'll ask Robert to take the last word. The question for on market reform what happens to
Yes, so I think the question may be even wider so because we're also talking about. Maybe I should just clarify to start off with that the last replenishment of the global fund was the most successful replenishment ever, with $12 billion mobilized. So it is true that the financing in Rwanda is declining slightly, but globally it has actually, from the global fund perspective. When it comes to efficiencies for Rwanda, I think I would go back to the results-based financing model that we have. When I first started working with Rwanda, we had many arguments in the past about budget allocation, can we fund this, can we fund that, and to be perfectly honest, some of those discussions just were not the best use of time from Mrs. side or from my side. I think the great thing about this results-based financing focusing on results and we allow Rwanda to take the decisions necessary to reach those results based on the financing we receive from the global fund. So we are, of course, here to support Rwanda in achieving energy efficiencies by helping to connect with the global service provider or helping through other ways of making innovative financing mechanisms available for the Canadian mobilization. But in the end of the day, it's really up to Rwanda, it's Rwanda's responsibility, and it's Rwanda's big actions on this new way of working, which I think is beneficial for both. In terms of procurement, we have done a lot of work within the global fund globally on market shaping, and our procurement team at the global fund have in-sourced the procurement and we've been able to negotiate much better prices. We see, for example, the price of bed nets have been reduced significantly. And we use framework agreements to much larger extent. And we hold demand to much larger extent. Now, this does not mean that we're going in and taking over the procurement functions for countries, but it means that countries can still benefit from these agreements that we agree. Thank you.
For advocacy on the introduction of treatment, particularly through the action on generics. I think if we step back a little bit, we will appreciate that one of the biggest revolutions in this area is the space given to generics. I remember when I was much younger, when we started reading documents on this pandemic, you will recall that the cost of one tablet, or let's say the treatment regime, one was estimated about $1,000 or so. It was in the thousands anyway. And I think you will recall that the UN and the Intellectual Property Organization, of course in partnership with other activists, who will always be remembered. I think the Minister of Health made reference to them. The advocacy to allow generics to enter the market and treatment, particularly in developing countries. So I think there is still room for action there. Today we're talking about further combination of the drugs. But that advocacy will still have to continue through partnership between the UN, the government, and the other players. So it will definitely continue because we will be exploring all possibilities to attain sustainability and reduce the cost of treatment. This is one of the key avenues for dealing with sustainability complexity.
The final question is directed to the Senator.
Key population, basically sex workers and the stigma. As you know, culture in our penal code, sex workers and it's illegal. But you know, in other hands, the majority of them are HIV seropositive. So, for the government, you have to go to them to sensitize them, and they say that the issue of poverty, if they have other activities, if they have to be cooperative, if they have incomes, I think it will be easier. So it's the issue of community. Maybe it's the problem of mindset you have to deal with. You can't say for that, but the issue of poverty and why we have sexual workers. It's the main problem, and according to the strategies of the government and parliaments, it's the issue, it's over citizens of the country. So we have to deal with, but in order to sustain them and to have over activities. Thank you.
And that we can pick pre-qualified by WHO and Global Fund so that we can buy. Because the last branch of things we buy and even we see from PMI was fake statements for more than $20 million. Complain globally. So I would like also Global Fund to accompany the country, PEPFAR also, to sue countries. And one year that we are asking that. This will assure that quality service to the population with the decrease in mind. We could not let it go. It's a crime. I will not want to know why because of those fake deadlines. Thank you.
Thank you. Thank you very much for having me, by the way. I very much enjoyed this debate, and I think it's very impressive. I learned a great deal. And we've heard very much about the progress that's been made in Rwanda on the delivery of services against very limited resources. And indeed, Rwanda is known all over the world for an impressive level of service delivery, given the relatively low level of resources. It's a key example worldwide of what we're planning to do. There are many challenges to face that were pointed out here. We're in an environment of declining funding, and that's likely to go on for quite some time. And there's a high level of new cases of HIV and an ever-growing number of people living with HIV, and it's obvious that the epidemic is going to stay with us for a long time to come, and we need a sustainable. But it seems that there is here at least a good basis for that. There are plans in place. What's needed now is a more careful analysis of where the funding gaps are, and the realistic aspirations and the goals for the future. And the amount of fiscal space, how much more money is it possible to actually spend on this, and what mechanism or another. Actually, the political context, I've said this before, but the question is what is the most practical, what can be most easily changed, and what can be done without having to change a law. And all of those things are entirely specific to a specific country. There are not that many lessons that you can take from and where are the key bottlenecks, what's actually preventing services. So, just in conclusion, I think there's still a steep hill to be climbed, and it's still there, and there are many challenges in front, but it seems that we are at least on the right road, and it doesn't have so many bottlenecks. I just want to thank everyone for your attention during this session, and let's please give a round of applause to our panelists.
So, a round of applause to our panelists while they are getting back their seats. Thank you so much. This was a very enriching. So I want just to give a heads up of the next sessions. We're running short of time, so we're trying to squeeze the next agenda so that we can see them all and keep looking at the new and interesting information coming on. So we're going to break a very short one, 10 minutes. So we'll be outside. There are nice posters, original researches from young researcher. That will be wonderful to see. After 10 minutes, we'll be back. And what we're going to look for, we have young researchers who have done, exactly what our key panelists were talking about. They have interesting data to look for. So we'll create two panelists also from those young researchers who will be willing to share what they have done and to share their knowledge and their findings. So we'll be glad also to see the audience that we're having here back in 10 minutes to also encourage those young researchers and also learn new information. So thank you so much, and again, we're looking to everyone present here to be back on time, and also we encourage that you all stay here so that we'll be all together to provide our warm welcome to our guests of honor, Her Excellency the First Lady of the Republic of Rwanda, who should be coming to to cross our conference. So it's a few hours. Keep enjoying the conference. There's a lot to come, and we are grateful for your presence today. Thank you so much.
Thank you. Thank you so much. Go to media online and stay there because we're streaming this online. Let me first mute this microphone.
So all the session will be in this room. We will no longer have a parade as you have seen in the agenda. So we will back here to follow the health systems and the psychosocial.
All right. John. Tell him to come. Guys, good job, but focus on your own stuff. It's not your business how to tell anybody what to shoot. It's not his business telling him how to shoot. You guys are just supposed to listen. Just listen to either me or him. The reason I put him on it eventually, I said, okay, at least if I'm explaining, maybe I talk too fast and you might not hear me. If I tell him, okay, I want 2 shots, and he says it to you, it's easier, so that we can all be on the same page. Right now, we streamed, thank God it went well, it looks good. Card is full. Where's John? Really good? It is really good. The card is full, but it's not, see, look, when I say don't move your camera, I mean don't move your camera. It's a conference. There's no dynamic shot. We're not shooting a movie. It's not a music video. There's no need to be super. You don't. I said those motherfuckers. And I'm not talking to a person like that. I'm not calling anybody. So anybody else will come and take the names, come and face me. So you don't talk like this. It's annoying. They did their job. That's not the song. They did their job to affect what we needed to do. And then you guys kept on asking me the audio, this, that, because client was somewhere decided to be sitting in front of me and not ask any questions. And this was what he was doing. And we said, I'm not afraid of that bullshit. Anybody else it's not your fault.
Boss, la solution umugozi wo gushyira kuri projector imwe kubira ntabwo ari bigomba kujya
barashakaho nose
barashakaho
video
mbabure
barashaka umugozi kugera
hariya ntigaragara gusa babona ko bitagaragara gusa babona ko bakeneye
barashakaho video
barashakaho
kambaza neza nanuza uzi transport turagira inama iratangira ryari
bagiye gukora pause
change time and so for me so I gave exactly 1 time
bambushije gufata nakaguza abone kacaja
at Serena Serena, I can where you want, where it's easy for you. More than 10 center, okay, it's okay. Okay, 4 p.m. Okay, I have. Okay.
Boss, stress myself.
Okay, okay. Yeah, what are you calling? Wapi? Wapi? Kilikuwa huko. Kuzurumva kumva.
Chris, tu kuambiwa kwa nini?
Les gens qui ne voient pas, ils jouent la musique. Hein? 750, 600. Tu sais, il y a les gens du NTP qui suivent avant les marchés. Merci.
Cristiano Souza. Cristiano Souza.
Muhamagara. Telefone yawe icyagiye.
Yes.
Iri. None se biri kwinjiza mu bingi. Ntabwo bose makiniki. Tutabure. hano inyuma none
Zatasiyo yarandi yize muri izi yakubwira
Sasa ikintu ukora wowe presentation uba uzifite hafi umuntu wambaye inkweto zitatu usanga utazi widerura yirukanka ariko utagendera ku kubwira sasa ibyashoboka bihuta inkweto zitatu
muri ya sare ariko asigayemo icyayi fanta isigayemo ni tonike hano harimo inzu ituruka hirya
zimushizeho izo muhaye arazifite umusibe iziriho hano umuntu yasezera ngo mushibe zisigaye uyisibeho nayo yaraye
John nta cyayi wasize mu rugo
kurutse uzashyira ariko umuntu ari kumenya kuri telefoni bakamuta hari resita udashaka ariko wari ubwira fata yataye mu
Valente.
usubire ku makamyo
ntacyo ntabwo ngenda ubwira yambaye kuteri John
I asked the brother speaker here. Where's John? Yes. John. See, and they left their cameras, John and this guy. Can you tell him to turn off his camera? He's not on camera. Stop. Turn off. Where's John? John
Champion. John. Ngoja kuri kamera. Tunajya gushaka Kristo.
The problem is I don't have a mic in.
Is this one?
Yes. You know what has happened is they were supposed to give me a live streaming machine, which they did not provide. So I had to create my own, using my own Ultra Studio Pro, my computer and everything. So my major issue now is I'm using on live mic from here, like to take the audio in, which then takes in all the ambience and everything. So I'm trying to kill, even if it's a speaker, because if it's loud enough, then I can balance the sound here and just, it's just for the stream. I just want to be able to kill all this conversation and if it's possible, but if it's not, I will.
You don't have a small speaker.
Yeah, I know.
Those are not mine.
I know, that's a. When you pointed at your speaker, I said, your smallest speaker, this is it. So I was like, what? I said, you have a small speaker. He said, this is my small speaker. I'm like, yo.
Look at his height.
No, you know that I've gotten used to it now. When I first came to Kigali, I was afraid of everybody. Because everybody's here. Everybody in Kigali was here, except you ain't.
Hey,
So,
I'm female, I'm allowed.
no, you're Kenyan, you're short. You're like us, West Africans.
Connected. Is it possible to move?
Other presenters whose abstracts were selected. Actually, you can have a stage here. Thank you very much.
Thank you so much, Dr. Saga. I'm pleased and honored to be here and to call upon the presenter. Now they have come to be panelists, presenter. So we have the way we were instructed to work through this session. We are going to have all the presenters come up front, and I'm going to introduce them quickly. And then we are going to tell you exactly where the abstracts are in the book of abstracts. And then the presenters are going to talk about between 3 and 5 minutes. I know it's unfair, I'm sorry. 5 minutes to talk about the backgrounds, things, the intervention and the key finding. Okay? I hope you agree with that. So without taking too much of your time, I'd like to invite first of all Dr. Neil, Mr. James to come up front. Also, invite Dr. Albert Tuichini, Dr. Bezerand, Dr. Mazi, Dr. Zuberi Muvungi. Dr. Albert is working at Rwanda Biomedical Center, as well as Dr. Nemazi, who is the head of MNE division. And Dr. Zuberi is one of our doctors in the Bushenge District Hospital. And at the same time, invite David Wilson, who is working at MSH, Jean Bosco Rutaisire from Rwanda Family Health Project, as well as Nadine Karema from Partners Health. Thank you. Maybe I will just take the mic. The way we thought that we are going to organize this session is first of all to tell you exactly where our abstracts are located in our book of abstracts. So for the first session on finance, you can check page for the first abstract. by Albert, page 49 and page 51. And then, without taking too much of your time, I'm going to request the first presenter, Dr. Albert, to tell us briefly about what is the background of certain national strategic planning and prioritization, what experience of his study, the intervention that he did, and the key finding, the key message that we want us to take. And this session comes right after the discussion on funding. So let's hear from our experience what we did found from different studies. So, Dr. Albert, you have the mic? What? So let me tell you about OFEA. OFEA is optimizing the response for prevention of HIV efficiency in Africa. So we did a very good study with the RBC team led by Dr. Saba and myself from the school. And we did that across the world. What is the cost of having prevention services? Can you guess? Can you know more or less the cost of HTC in Rwanda? Who can guess? No idea. So what we did find actually was that HTC per client cost us around $6. And this is based on 2012 year. And PMTCT was $38. But when it's come for testing and putting these positive clients on ART, the cost was much higher. From $6 to 1,600 USD per client. Now, my question is, why do you think this is happening? Why do you think you have this huge cost from testing of $6 to 1,000? So I guess now Albert has the mic. I'm going to pass on the mic to Dr. Albert to tell us about the backgrounds, the and the key funding in 3 minutes. Sorry.
Thank you very much, Chair. So, the aim of this presentation, or the aim of the workshop, was to share the experience we had while developing the national strategy, introducing the aspect of prioritization. So, as background, this MSP was to be developed in the context of global as well as national commitments to decrease both infections as well as death related to HIV, while providing the same opportunities to people infected or affected by HIV. But again, specifically for Rwanda, the CMSP had to be developed in the context of steadily decreasing external funding or support, which was around 7%. Looking at these two elements, we had one vision to a strategic plan, which is ambitious, with aligned overarching goals, but again, that is which is a realistic plan, which can be implemented using the available resources. The plan had to be cost-effective, just including cost-effective interventions, executable plan. So to get that, with all these criteria, we went through 7 steps. The first one was to identify where we were, where we are, to define where we want to be, to lay out how we go there. Then the fourth step was to see how much this will cost us. After having that cost, we again went back and see how much are we expecting to have in terms of these resources. This led us to build or develop several scenarios with different impacts, and we ended up choosing the best one impact with the means budget. But again, we had to operationalize that strategic plan in order to allow implementers or program to be implemented at field. So from those steps, we ended up having a well strategic plan grounded in epidemiological evidence, which was prioritized but again operationalized. As conclusion, we are saying or we are recommending evidences that will be used while developing strategic plans or strategies. Thank you very much.
Thank you so much, Albert. I think Albert tried to get the time, so we are now going to invite Jean-Pierre Lemanzi to use the same strategy and to keep the 3 minutes.
I will try. So, thank you so much for the opportunity. And I think I had a good introduction when we talked about it. Because I'm going to talk about a similar study that was carried out in 2010. It was a multi-country study that was looking at the facility level costing. So it was not including over facility. It was all about what the cost going to the patient taking drugs at the facility level. So, but I'm not going to talk about the whole study.
Dr. Zuberi, to keep the same principle again. 3 minutes, thank you.
Thank you, Chair. Dear President, distinguished, thank you for the opportunity to present or to give our small contribution using evidence to save lives. Because time is really very short, I'd like to start by the end. My presentation, I think two things are more important, most important. One thing is the accreditation process. The other thing is how do we scale down or do we improve health care provided to people living with the HIV/AIDS. Right. Someone will ask me, what is the accreditation process? I believe that accreditation process is a small part of Rwanda vision, 2020 vision. The vision is 2020 is just to do whatever we do in respect of international recognized standards, and of course empower our people and get them from poverty to medium income country. Now, what we did in Bushenge Hospital was, in our study, we tried to see if the accreditation process a positive impact or effect on the way we provide health care to people living with review criteria where evaluation of clinical stage, screening of STI and TB, viral load, CD4 count, medical consultation, psychosocial support, failure of treatment. These are the findings. As you can see, the evaluation of clinical studies is done before the implementation of accreditation. Consultation only 3.4, viral load 16, and psychosocial support nothing. The screening for STD and CD4 count as well were done even before the implementation of the accreditation process. Now, what our conclusion is that the accreditation process has enhanced the compliance to standards, mainly clinical standards. Using can identify these gaps of non-compliance. Quality improvement principles are used to determine
quality, effectiveness, efficiency, the individualization of services, and satisfaction of services of our customers. Now, based on the effects of application in HIV management in other countries, Uganda, Kenya, and Asia, this process of improving quality of care for people living with HIV/AIDS. Now, some is to strengthen the application process countrywide. The policymakers work basing on the application process. Remember, Vision 2020 is the basic whatever we do. Now, the hospitals must national standards as far as internal developed policies and procedures. And those policies and procedures, the health providers must have a culture of documenting. This is why we wrote so many abstracts in the. So just keep it up. Thank you very much.
Thank you so much. Right now, I'm going to invite Dr. Neil to talk a little bit of where we are finding the next track of abstracts, and then also to let the presenters go through 3-minute presentation. So if you have a question, keep it, write it down, and then we're going to have a joint section of questions. Let me just introduce me. So please go ahead.
Thank you very much, Dr. Janine, and thank you to our first 3 speakers. We're going to build on the theme of health system strengthening and really leveraging HIV platforms to build the health system and think a bit more about data information systems, health information systems, e-health, utilization for quality improvement presentations. So I'd just like to invite our first speaker, David Lodge, to begin with his presentation and to continue on the theme of efficiency with your key findings. Thank you very much.
Thanks very much. I apologize to those of you who know me as Randy Wilson, because when I was that, I think many of my colleagues are familiar with me as Randy. I wanted to speak about quite a brave initiative that the Ministry of Health and RBC taken over the past 11 months. And that is the transition of the HIV reporting from a proprietary system over to an open source system known as the District Health Information System. And the background to this is that Rwanda has been using the TRAC Act, which has been designed and implemented primarily by Vaxiva, since 2006. It was an idea ahead of its time, I think, that period, because it had introduced quite innovative use of mobile phones through integrated voice response. In an environment where there was very limited internet access, yet Rwanda's phone network has been very good. RBC has been using that platform until just last month, in fact, but came under some pressure to make a switch and do a transition, partly for cost reasons, in terms of country ownership. They had quite an effective experience implementing the DHIS2 system for a number of systems throughout the country. The HMIS, the TB, even the new performance-based financing system have all been migrated over. And it's a system that they've discovered can be maintained within the ministry and RBC. So there's been a great improvement in terms of ownership, in terms of ability to configure and maintain the system in-house, in a sense. The other main benefit, of course, was in terms of costs. The $350,000 a year that it was costing to maintain the system, it can be brought down to about $60,000 a year. That includes even 2 support staff within RBC to help to manage the system. The key findings in that context is about 11 months, all HIV focal points and data managers in every health facility in the country went through basic training. Training made simpler because all of the data managers had already been using the HMIS system in the past on the same platform. Still a couple of things left to do. There's quite a
forward. Project, when we started working with them, what we did that led to information that I will share with you related to use of data to make decisions. We engaged them, as my predecessor presenter said, there's a lot of data in my facilities. So the idea is that how is this data being used at the local level to drive decision making and actually improve quality of services. So we trained members of HLTs, the directors of health and the district monitoring and evaluation officers on how to clean and how to analyze data. And we also took them through sessions of data quality assessments, and each DHMT meeting, because they are holding meetings on a quarterly basis, our teams work with them to prepare data that they can present to the whole forum, and on that data to inform their decisions. Data is derived from HMIS, and what we have observed in one of the districts that we supported, specifically in Negatari, in 2013, in the last quarter of that year, there were 6 babies reported who did not turn up at 6 weeks for HIV testing, which means they did not also have HIV prophylaxis according to the national guidelines and protocols. What the HMTs did is they gave this feedback to the health centers where this observation was made, and the health centers linked with workers who conducted home visits. And by the next quarter, when the HMTs met, all the 6 babies had been retrieved and actually provided with the necessary care. So, based on that, we are the lesson that we learned and that we would like to share. Actually, if properly supported, are able to impact service quality, they are able to, based on data, and make real decisions and address problems so much.
Thank you very much for the presentation. I'm hoping that I can get the name right on my 3rd and final attempt of a presentation. I should have a good chance. As Nadine Karima, I'm one of her supervisors, so I think I know her name well. I invite her to speak on quality improvement through data utilization and describe a model that they have.
Thank you. So my part about looking at the use of electronic medical record data to tackle 3 issues in the pipeline. Just for the background, we looked at 2 innovative systems. One is the mentorship and enhanced supervision program that was implemented in partnership with MOH at the IH site and now being scaled nationally, starting in 2012 and still ongoing. And the other system is the electronic medical record system that Randy mentioned, which is an open MRS platform. We looked at the use of electronic medical record system for patient monitoring, clinical decision making, and evaluating the quality of the care that's provided. For this project, we looked at the setting that we used was the health district. We looked at 13 facilities, and the the clinical mentors looked at the viral load testing, which Dr. Zubair mentioned, was at a low of 2.8%, and using quality improvement projects, they decided to take it from a low 2.8% to a goal of 50%. With the interventions, clinical, facility, and district, at the clinical level, the mentor sat down with the clinician, observed the results from viral testing, and using EMR, generated from EMR, which are consultation sheets with alerts and reminders on patients that are past their viral testing due date, because viral testing, for those who are not clinical like me, viral testing has to be done every year. So we looked at the alerts from EMR, saying whether a patient was past their viral testing or not. And the second phase, besides looking at who was overdue, they also looked at EMR data to progress, because the intervention was done in 3 months. It was from November 2012 to February 2013. And at the facility level, the mentors generated EMR monthly or aggregate reports to look at all the patients that were tested. And at the district level, they conducted data sharing meetings with various facilities just to look at the data on how to improve the results. Our findings were that after the QI intervention, viral load testing went from a low 2.8% to 63%. And remember, the goal was 50%. So that intervention was done by the mentors, but EMR, or the electronic medical records, was used as a tool to track progress and to also identify any gaps that they had. And without timeliness of electronic medical record system, as you could see from the previous slide, we had pre and post intervention, we had 2,223 versus 2,387 patients. So if it wasn't for the electronic medical record system, clinicians and mentors would have had to flip every single chart page and look at the results. So EMR was used as a tool. So the conclusion here is to say that EMR can be a good source for data, to be a good source for letting clinicians and health facilities know whether they are on track, monitoring, clinical improvement of care, and tracking any progress. Thank you. Wow, we did it. I think these guys need a round of applause. From 15 minutes each to 3 minutes each. Thank you so much. And we got all the message, all the key findings. So thank you all. And also to kind of think about where we come from costing. What do you talk about cost? And then we go to evidence-based. I think we needed to understand how much is that to not only keep the cost as efficient as possible, very good service so that we can reimburse the sustainability. Without taking too much time of talking about this, I would like to open up to the audience. If you have questions, please introduce yourself and tell us your question is directed to whom. So questions are welcome. If there's no question, that means you didn't get anything. Or you get everything right. Edward is looking at me. Do you have a question, Edward?
My question is to Dr. Wilson to begin with, maybe this is provide a little bit more information about could you provide a little bit more information on
Okay.
My question is Dr. Wilson. My question is, could you provide a little bit more information on the magnitude of the service that's going to be implemented? You're going to be covering the entire, all of the districts, all of the health centers, and then where does the data go to as well? Obviously, this is a tremendously rich opportunity, and it sounds like it's going to be fantastic. But over the years, throughout all countries in the world who have tried to use it as routinely collected data, the challenge is that they have excelled in some environments and much less so in others. Rwanda is one of the countries that values the use of routine data. So when do you think this is likely to be useful at a national level?
Yeah. Nathan?
Do you want to say the questions? Yeah. So mine was more of a comment and to congratulate the last presenter on the quality improvements in viral load, and to make, because by coincidence today in one of the South African national newspapers, there's a article just on this very topic of how do we do a better job. So they did 2.4 million viral load tests last year, but they really don't have a good idea of how many patients got a viral load and how many viruses they got, because they don't have a unique patient identifier to link to the NHLS. So this question of, we've all done a very hard work to introduce this high-tech capability of monitoring treatment into resource-limited settings, but it's a huge missed opportunity if in spite of introducing this technology, the results aren't. It's very laudable that you're following it up with this study, and just to make the point that even countries that have been using the technology for 10 years are.
Thank you, Nathan. We can take 2 more questions.
Merci beaucoup.
Saban, Dr. Saban. One more? Okay, one more.
Nous avons la RDC. Je voudrais savoir la personne qui a présenté sur la PTN. Ils ont attendu que les enfants après 6 mois. Alors que le représentant de l'OMS, apparemment hier sur le micro, il a présenté un test de TBS, Red Blood Specimen, qui, à mon avis, permettrait le diagnostic précoce chez les enfants de moins de 6 mois. Pourquoi est-ce que dans le COSA, ici à Paris, on a attendu que ça se passe 6 mois après au lieu d'utiliser ce test s'ils existent?
Merci beaucoup, monsieur. Je pense so. I'm going now to pass the mic to Randy to respond to the question. Maybe a comment from Nadine, and then we end with Randy.
Sure, thanks for the scale of the system is nationwide. We've progressed a lot since 2006, when there were mobile phones used primarily, because all health enter the data using a web browser. So that was relatively easy because we'd already been using that approach for the HMIS. Your question about where does the data go is a very, and I think David's presentation speaks a little bit to the fact that one place that it does go is the districts and the district health management teams. The fact that it's web-based means that it has ability for data use pretty much anywhere, particularly across Rwanda. And that is something that we're building on, particularly focusing on specific information products that support either strategic planning, so that when they do the 5-year strategic plan, the system produces that. So each district will actually know how they sit and how they rank on various HIV and other health indicators. And then they build that into their situation analysis. But there's a lot more day-to-day use that I think Nadine spoke more to, about actually getting the system to sort of identify gaps and sort of proactively some information about areas that they need to focus on. So Perhaps the last point is that we've set up now a national warehouse which pulls key indicators from all health programs into a single platform. And that we've already moved the former data from the TrackNet system into it, but as of this month, we'll be moving all of the data from the DHIS system. So that will eventually be a more broad platform for use by researchers, people at the School of Public Health, and of course provide access to data from HIV, primary care, etc., to the full range of stakeholders in the country.
Thank you so much. I hope I did say 6 weeks, 6 months for infants born to HIV positive mothers getting tested, because the national recommendation and national protocol for Rwanda recommends 6 weeks for the babies to come be tested. So just to reiterate and clarify that what I said, and I hope I did say that, is that the DHMTs are maximizing this effort, data that is coming through the system, and making sure that babies are tested at 6 weeks, not 6 months. Thank you.
Right. Thank you, Nathan, for the comment. You're right. It's not just about entering data, it's about using and even using that information. Because if you're not using it, we want to go from data to information and using that to drive better patient care. And I would like to commend the government of Rwanda because since February, the Ministry of Health decided that EMR, or the electronic medical record system, has to be used by clinicians directly. So instead of having just data entry staff entering the data, it will be a clinician entering the data and using that information. And that's commendable. Thank you.
Thank you so much. I guess we are running out of time, but I would like to thank the presenters here and also your participation. Yeah, Honorable Minister.
Congratulations to the panelists. But I want to point out to the audience that the seems coming from various horizons, but this is all the Rwandan program. And we put the use of ICT so high in the government of Rwanda that yesterday in a meeting with the Right Honorable Prime Minister, there was a decision to create a national council for that will be chaired by Honorable Right Prime Minister for the use of ICT in all the sectors, so that we use it in an appropriate way to reach our Vision 2020. And we were discussing in the first panel how to save money. You hear led by Dr. Jean-Pierre that we can save 40% of the price. And you can see that it's the use system that allow the clinician to understand what they do, but also us at central level to take the right decision. And as you said, when we don't know the data we collect, it's just data. No, it wasn't that. It's just waste of time, waste of money, and have cupboards and computers full of things that we don't use. And for me, it's a very important panel, because this is the management of the health system of tomorrow. And the electronic medical record is beyond HIV. Polymerized in 2005, and now we have electronic plan to have in 100% of our 700 health facilities. And we want each and every one to understand what they enter. And it's also, again, I want to phrase that it's in the frame of the building. Because if we go there and we ask somebody, so you had 40%, what does it mean? And if he doesn't know what it means, is disqualified. Because the person who sweep can also use a computer and enter that. Thank you.
Wow, thank you so much, Honorable Minister. I think you just said it very well. Data, evidence, sustainability, and look at your cost. We just got another grant with the Minister of Health on how EMR can inform us on loss to follow-up among peers. So this was it's funded by CTC, thank you CTC, but it was tough, I have to say it. But you know, more people are now using EMR to inform policy for evidence based. So we don't want to waste money and think that we don't know if they're working. Now let's use the data and get evidence to government. Thank you. Minister?
Yes, and also to say that Dr. Zube presents through the accreditation process. We use an international way to accredit King Faisal. It was accredited twice. After that, we went for the other referral, all the provincial for hospital, and through new referral. And we want all district hospitals to be accredited. Can we see the data? It's incredible. HIV, but we should see for neonatology. Dr. Zuber applying that got no death within a month. So, knowing the cutting and use of data, accreditation for, and we have also PBF for quality. We have decided to merge the two because quality is quality. Now we are going to give performance-based financing according to the process and the journey of the facility to accreditation. I give you an appointment in 5 years. I think we will not recognize
that. For the session chair, the presenters, and the honorable minister for the very good comments. Let's go for that round of applause as we invite the next. So we talked about financing, money, health system, M&E, strong M&E. Now we are going to talk about community and social studies. It's very important discussing this, but the community level is where this will happen. So the next session, and it's the last session before we go to the closing event, is going to be led by 3 people that I'm glad to introduce. I'll start with Dr. Agnes Nyiranyugwa. Dr. Agnes has a PhD in economics from the Western Cape in South Africa. Just 10 years of experience in research and lectures in the United Nations Population UNFPA as assistant representative. Is in charge of population and development issues. Thank you, Agnes, for joining us. Agnes Nyiranyugwa. We have also Michelle L, who has an extensive experience in OVC programs. Michelle has been working in Rwanda and Uganda, helping to set up gender programs and guidelines. Michelle is trained in business administration and political sciences, and she's currently coordinator of OVC programs with Higa Uwe project supported. Thank you, Michelle, and welcome. We have Inyas Ndiamabo for chairing this session. Inyas has a Master's of Public Health and is Executive Secretary of Rwanda Interreligious Council for Health, called REACH. And this organization is grouping more than 100 religious organizations helping to fight HIV in Rwanda. So welcome, Inyas. The other 3 chairs of this session, they are going to invite the presenters for abstracts selected under this track. Thank you very much.
Thank you very much, Dr. Safar. Without further approaching towards the end, and I'm very delighted to be here to invite the next, I won't call them presenters because it's a panel discussion. I'd like to introduce rather Ms. Tona Isibo, who is an M&E specialist and research professional working with the USAID's Higa Uwe program. If she could come forward, please. Our second panelist would be Dr. Vincent Cezriera, who is a clinical psychologist and also head of department with experience in mental health, anxiety and depression, working with the University of Rwanda. Dr. Sezibera, you are most welcome. Our third panelist would be Miss Letitia Umulisa, who works with We Act for Hope as a pediatric HIV plus and young mothers program. Welcome, Ms. Letitia. Last but not least is Dr. Jean Kagwiza, who works for the University of Rwanda. Doctor, welcome. Yeah, thank you very much. We'll listen to the first hearing. Remind again everyone, we have 3 minutes to give us really straight to the point, key facts, what are the methodology and what are the key findings. We are most interested in the key findings, and I remind the audience that we have a lunchtime presenters so that we could get more insightful of their presentation. So the first presentation will be by Ms. Tona Isibo. She talks about promoting health behaviors among vulnerable youth through school-based club approach and results from USAID. We have 3 minutes, and the presentation in the book of abstract can be found on page 90. So,
thank you. I'll start with a very brief overview of the program. It's a 5-year PEPFAR USAID funded program with the overall goal to increase the use of health and social support services for the most vulnerable, including orphans and vulnerable children and their families, and households infected or affected by HIV/AIDS. The program provides a comprehensive set of services for families, including life skills development, which is provided through school-based clubs, known as RAZ clubs. So the RAZ clubs life skills development, life skills education, peer mentoring, and psychosocial support for vulnerable youth within a school setting, and support youth to adopt healthy behaviors and be able to develop healthy relationships. And through these clubs, youth are empowered to make informed decisions that will help them to manage and avoid risky situations, including protecting themselves from HIV/AIDS and sexual and gender-based violence. Since 2010, the program has created 242 clubs across 16 districts, and we've reached over who are in secondary schools and TVET, technical and vocational education and training. We've also trained teacher mentors and youth leaders who are the ones who. In 2013, we contracted to evaluate, to assess the assessment, to help us better understand what the key outcomes were for the youth we're supporting, and to also help us identify promising practices so that the intervention beyond the life of program. The assessment gathered quantitative and qualitative data from students who were members of the RAZ clubs and from students who were not members of the clubs who acted as a comparison group. We also conducted focus group and key informant interviews with teacher mentors, sector officials, district officials, and school administrators to triangulate the data and validate the data. With regards to life skills, we looked at different policy indicators: self-confidence, positive behaviors, leadership and decision-making. Shows that RAZ club members showed compared to non-members, and we're showing better results in terms of these life skills. And we also saw that RAZ clubs were performing much better in school encourages them to focus on their studies, encourages them to set goals to be able to improve on their academic performance. The assessment also collected evidence through qualitative interviews, which provided evidence of youth who were transformed through the clubs and were able to turn away from risky behavior, including early sexual initiation, alcoholism, and drug abuse. So in conclusion, the club model is affordable school club model, which provides vulnerable youth with an opportunity to develop life skills and support systems to help them avoid risky behaviors and to protect themselves from HIV, AIDS, and other risks. And to ensure sustainability, we continue to disseminate our research as well as our materials developed for the Alahizi Club model to different stakeholders and different partners. Thank you.
Thank you very much, Ms. Tono. The second presenter will be Dr. Vincent Sezvera. Presentation, or rather the discussion, it will be on the predictors of suicidal ideation and behavior in children affected and unaffected by HIV in rural Rwanda. You have no more than 3 minutes, please. Thank you.
Thank you very much. For the background of this study, we were inspired by the fact that the HIV infection is and also what is known from the existing findings. There is a relationship between HIV, AIDS, and mental health problems. And most of the studies used adults, young children and adolescents are not prevented from these mental health problems. Studies also know how, for example, depression in this specific population of children infected and affected can lead not only to self-harming behaviors, but also those who are not attempting, for example, suicide, they may be at risk. So this was part of the study. The purpose of the study was one to compare mental health problems among infected children as compared to those who are affected, to men living with parents who are infected, and also those that why do we want to do this. It was also to look how suicide ideation and suicide behavior present in this specific population and how the suicide ideation and suicide behavior are related to HIV status. But we to understand how, depending on the different demographics, there might be any difference. So with regard to the methodology, one, we selected the sample from the existing records, the electronic, we selected the sample of 683 participants, and we collected using standardized measures to assess not only the social demographic information, but also to assess the participants, and included the depression, some conduct behaviors, conduct problems. We also asked about caregivers' mental status. We looked at even any social support available in the society. We analyzed data because the data were quantitative. The analysis was also quantitative using well-known softwares, statistical. The other one, we want to understand how prevalent these mental problems. We could find that some of the participants, almost 25.7% of the children were meeting all the criteria for a depression diagnosis, and also 30
were reporting conduct problems. Looking at the suicide ideations and suicide behavior, it was also the same. Found that almost 20% were reporting suicide ideations, and interesting numbers. I'm saying interesting from the research, but it's not interesting experience. It is an alarming situation if we consider what does it mean. Comparing these different groups, for sure, it's infected and those who are living in families with infected parents are reporting highest mental health, mental burden. We want also to understand predictors, and predictors we looked at protectors, risk factors. There are some factors which are significant predicting the suicide ideations and suicide behaviors, and these include primarily the child mental health status. Those who are depression were also unfortunately likely to be reporting suicide ideations and suicide behaviors. They say when we look at the parenting style, the family within where there are conflicts or families using harsh punishment, these factors are really risk factors, but on the other side, good is protective factor. We looked at also at the socioeconomic status. We could see that those who are able to satisfy the basic need likely to decrease in suicide behavior. To conclude, because of the time, what we learned from this exercise, this is probably it's not just that the IRV is improving and increase in life expectancy and make the HIV to be a chronic disorder. We thought that we should be looking at how to address the psychosocial stressors, especially for young children and adolescents. We can ask ourselves what will be the next stressors for them, being a young adolescent, and probably how to deal with friendship and relationship and get married and get children. And admitted that we found that those who are old enough were the most at risk. We thought probably the intervention can be integrated where we may have community-oriented, psychosocial-oriented interventions to work on that strain and stress from the most stressful HIV. We thought also probably community health workers can be trained on these issues related to mental health problems. At least they can be able to identify and make a kind of rapid assessment and refer the children or adolescents who need any mental assistance to appropriate structures so that they can get help instead of attempting suicide or any self-harm behaviors. Thank you very much.
Thank you very much, Dr. Vincent, for keeping the time as well and for the interesting topic. From predicting behavior to empowering HIV positive young mothers. What do you say about it?
My study was empowering HIV positive young mothers. As background, in 2010, We Out for Hope has formed a young mothers group in order to address their needs and also to promote support group among women. Stigma is a hard program. Depression, hopeless were persistent as major terms, and also a poverty among those women. What can you do to be more helpful? 6 young mothers participated. 12 of them are illiterate. As method, group met weekly for 2 hours at our clinic. 6-month program with 3 days a week. Research is organized and provided. All our students in research are we learned from this that when we provide the psychosocial support, economic and educational support for HIV positive young mothers can be improved. This can also help in other less developed countries. Thank you very much.
Thank you very much, Ms. Letizia. I think we are saving some time. Yes, this conference is not only about financing services, which is beyond monetary indicators. And now let's look at environmental functionality, ability, and environmental factors. Dr. Jean, can we have the floor?
Thank you very much, Chair. Distinguished guests, ladies and gentlemen. The data I'm going to share with you today is part of communication. And it's a qualitative part. I started by the quantitative, I get numbers, and I wanted to go to people, talk to people, and get their feelings, their perceptions, and their experience, how they live HIV. But not only HIV, but the complications from the disease and the drugs. Thank you. So before maybe saying something on the background, explain some key terms or concepts for this study. The first one is ICF. What is ICF? ICF is the International Classification of Functioning. And this is a new concept for disability developed by WHO in 2001. So WHO has looked at disability and said, no, this is something maybe we could do and look at disability as a holistic concept. And disability became an umbrella term for impairment, activity limitations, and participation restriction without forgetting the environment. The environment is like influencing all these terms and the person himself and how he lives with the disease. The second term is rehabilitation in HIV. Rehabilitation in HIV is not only rehabilitation as we know, but it looks at the way of the person living with the disease. So when we think about rehabilitating that person, we think about prevention, treatment, again from the drugs. As we know, the drugs have really improved the life expectancy, but how do you maintain this? How do you assist this person to improve his quality of life? Now, what is the rationale of the study? The rationale of the study was to join the evidence which has proven that the person living with the disability is experiencing complications for the disease and the drugs which have reduced his life expectancy, and his well-being, of course. So, now, what are we doing with these complications? We healthcare providers. Are we really tackling also those complications, or we are just focusing on the disease people have presented since the beginning of this conference? And what condition is resolved because, as you have been
Yeah, since the beginning, the CDC4 boots, it increased, and the immunity is increased, of course, and we are like gaining a lot with that. And it's a medical model of looking at things. So we now what can be the complications, and that's very different. And we needed to look at the nature of the holistic care we give to that person. Of course, in the first of this the study, we looked at the profile or the picture of disability of these people. The method, the quantitative method used was a focus group discussion, and we did this in 2 hospitals. What are the results? As I said, in ICF, the disability is defined as impairment, activity limitation, participation restriction, and the environment influences all this. So, what are the common impairments we found out? We found out that pain was a really important impairment, paresthesia, breathlessness, and loss of memory. And of course, we had other impairments, most important or the most common. Those impairments, they influenced the activity in daily life and participation in the social life. So that you could find, I've put some quotes. You could listen to the person saying, pain, I'm unable to walk. Because of pain, I'm unable to go to work. Because of pain, I cannot perform domestic activities and other impairments, of course. What else we found out was the factors influence. And among the personal factors, the most influenced factors or the most facilitating, because in the factors, in the personal factors, we have those which facilitated and those which limited. And those we found out it was the spiritual beliefs of these people to think about disclosure, how the person thinks he should disclose to others. And this positive thinking about disclosure was like improving the psychosocial well-being of that person and overcome the stigma that person has. But we had also these personal factors limited the functioning. And among them, we had stigma, an important factor to consider. And the most aged people were like complaining more. Then we had more the environmental factors. And in environmental factors, we divided them. The community and the family as a nucleus of the community. So that person had problems with the family, and not only also some facilitation. Like some people disclose that or share family, and that encouraged them in a lot of things, in getting drugs, in going to, in getting involved in the social life. The hospital environment, which is important to consider here. And in the hospital environment, we had the RRV clinic itself, really very supported by our patients. And also, I'm going to finish. And also the outside, the RRV clinic. And the outside RRV clinic, they do that. And what I want to share with you on this, it's like there's no link between the RRV clinic and the outside RRV clinic. Patients, they really feel belong in the RRV clinic rather than in the whole system of the hospital. And that is caused by, first, the referral from the RV clinic, which is having a problem, and the way the outside RV clinic, the way healthcare providers really assist patients.
Thank you so much, Dr. Jean.
I will conclude by saying we need to promote interdisciplinary, multidisciplinary way of working. Thank you very much.
Thank you very much. You just said what I was about to say. It's a multidisciplinary approach of resolving a problem. We won't have questions during this panel discussion. We'll have a chance to chat outside and to have more clarification. We won't leave the floor without giving a chance to my two co-chairs to just say a word to wrap up on the different presentations and taking the occasion to thank the panelists and open the discussion. The room in another occasion that should be given to us. So you have just one word.
Thank you very much for giving me this opportunity to say something about us. Have given us very wonderful presentations. We had the first one, we talked about the model to be very useful in increasing the performance of the secondary school students in terms of the life skills and also the academic results. Then you had the second presentation from Dr. Vincent, who showed that children have very serious problems that go up to suicidal behavior. This is very something that is very critical because I think suicide is the worst outcome of a life. So I think this is something we need to take seriously. And his presentation has concluded that if you can be able at least to meet basic needs of these children, the suicidal ideation or suicidal behavior, they are able to decrease. The third presentation was from Letitia from We Act for Hope. It was the previous one that young women who are pregnant, I mean HIV young mothers, they also show poverty, isolation, depression, and so on. And then if you can able to help them, group them together, they're able to raise some funding, they have been able to open an account, they have elected managers. So it shows that there is a lot of to do in that area. So we also had the presentation from Dr. Jean Kabiza, also about the disability, which also is a big problem. Living with HIV and having a disability, it's a problem. And it has showed that the environment, I mean the family, the hospital, these people, they face a lot of problems, ranging from self-stigma to family stigma, but also she has concluded with a very good note that the hospital environment tries to be friendly to this with HIV and at the same time having disability. So I think this is a small wrap-up of what we had from the discussions today.
Great, thank you, Agnes. And just before we're going about to go to lunch, I feel like we have some very inspiring things to talk about. And for me, it was two issues. Across the panel, you did an excellent job talking about opportunities to go to scale, and of course with the school-based clinics. But also with the suicide IDU, I think you've given us some new opportunities to look at how we can strengthen the quality of our services, both in the hospital and in the community, based on the new findings that you've presented. So thank you so much for helping us to learn some new elements that we can bring into our program here in Rwanda. And thank you again.
Thank you very much, our panelists, session chairs, and presenters. We're going to ask them to join their seats and give them another round of applause. I'm sure that we have just a few minutes towards the end of this conference, and it is a lunch that we don't want you to miss. It's very important also to continue to do our research and work. So I'd like to invite you to the lunch. It's going to be 30 minutes lunch. I haven't seen that before, but I'm sure you're going to make it using evidence. Children are going to proceed first, and then others going to go the same place we used yesterday, Downstairs is a nice tents that the lunch is prepared. You have different places, so it will be very good. We're going to come back here in 32 minutes to continue with our closing session. I would like everyone to not miss what is going to continue. It has been a great 3 days that we need to close and go back to implement. So please welcome back with our guest of honor joining us in 30. Thank you. Have a good lunch.
I'll be around for you.
Guys, well done, man.
How are you?
I need a hug.
Oh, you need a hug. Come to mommy.
I want to come to mommy too.
Oh, you want to come to mommy?
What kind of mommy is this one?
I don't know.
My real mommy.
I don't know. Just keep it there. Just leave it to mommy. Just
You just want to... Are you streaming? Are you streaming?
Because you look so tired.
Make sure you get your budget.
So how is it?
You did well. Let's go to the main camera. Check the screen for me.
The First Lady of Rwanda, distinguished guests, we are going to welcome us, and we will be starting our closing ceremony. Your Excellency, the First Lady of Rwanda, Honorable Minister of Health, States, the UN Resident Coordinator, ladies and gentlemen, good afternoon. We are honored to welcome our guests to this special event, closing 3 days of our International Scientific Conference on HIV, HIV research and pediatrics. It is a conference that has been attended by more than 400 people, coming from more than 10 countries, and and hundreds of selected researchers' topics have been presented, both oral presentation but also poster presentations. As a very special event this year, again we've had the representation from various districts, from all districts in Rwanda. They have been part of these 3 days of sharing the knowledge, the researchers' results, and the different challenges identified in the implementation of the HIV program in our country. This afternoon, we will be receiving recommendations from all the different sessions. We also will have the pleasure to hear from the perspective. It is at this time to welcome Dr. Sabin, who will be accompanied by Ms. Aline Soleil, who will be also presenting some of the recommendations. Please welcome them. Thank you very much.
Excellency, I would like to give the floor first to children. So Aline will start and we'll continue. Take the
Thank you. As they told you, I'm Ransome Aline. I'm going to present you the recommendations from children, but it will be in Rwanda. Thank you. Ibyifuzo by'abana ku
kuri 2014 International Research Conference ifite insanganyamatsiko dukoreshe ibipimo by'ubushakashatsi n'isi itera sida. Abana nabo bagize ibyifuzo batangaho, ibyifuzo bikaba biri mu bice bine. Igice cya mbere ni ibyifuzo mu muryango, gushishikariza ababyeyi mu kwita ku bana babo babaganiriza ku bijyanye n'ubuzima bw'imyororokere na virusi itera sida, ndetse no kubaha ibyo bakenera mu buzima bwabo bwa kugira ngo bibarinde kugwa mu bishuko. Bifuje ko hakorwa ubukangurambaga ku ababyeyi babo baba bataye, ko abo babyeyi bakwihutira kuzajya bapimisha abo bana virusi itera sida. Gushyiraho gahunda zo kuzamura imibereho y'abana bagizweho ingaruka n'icyorezo cya sida. Abana kandi batangiye mu mashuri, harimo amashuri hashyirwaho uburyo bwihariye bwo kwita ku bana babana na virusi itera sida mu rwego rw'imirire no kunywa imiti igabanya ubukana ku buryo bitabashyira mu kato. Ku bijyanye no kwirinda icyorezo cya sida no guhabwa serivisi z'ubuvuzi ku bana bafite, aha twavuga abatabona, abatavuga ndetse n'abatumva. Gushyiraho umukozi uhoraho ushinzwe ubujyanama n'ibibazo by'ihungabana. Abana kandi bifuje ko hashyirwa imbaraga zihariye mu gufasha amaklabu anti-sida mu mashuri no muri community. Abana bifuje ko kandi hashyirwaho uburyo buhamye kandi busobanutse bwo gukurikirana imibereho y'abana mu mashuri, cyane cyane acumbikira abana, hirindwa ikoreshwa ry'ibiyobyabwenge no kureba amafilime atubaka abana. Igice cya gatatu ni ibyifuzo by'abana kwa muganga. Abana bifuje ko bakwegereza imiti hafi igatangirwa muri community hifashishijwe peer educators babihuguriwe, hagamijwe ko abana babana na virusi itera sida bafata imiti neza. Abana kandi bifuje ko hakorwa ikinini kimwe gito kitarura kandi gifatwa nibura rimwe mu kwezi mu rwego rwo gufasha abana babana na virusi itera sida gufata imiti neza. Abana bifuje ko kandi hakorwa ubushakashatsi bwihariye ku bana babana na virusi itera sida ku bijyanye n'uburyo abana babona imiti igabanya ubukana bwa virusi itera sida, kuko mu bana bato habaye no kudafata imiti neza. Abana bifuje ko kandi hakongerwa serivisi z'ubuzima bw'imyororokere no kuzivugurura hakongerwa serivisi z'ubuzima bw'imyororokere ku buryo urubyiruko rurushaho kuzibonamo. Ubwo ni nko kubona umunsi wihariye. Abana bifuje ko kandi hanozwa ubujyanye n'ubuzima bwo mu mutwe, mental health, ku bana bose muri rusange, cyane cyane abagaragaza ibibazo bya depression na post traumatic stress disorder. Abana kandi hakorwa ubushakashatsi ku mpamvu zituma ihohoterwa rishingiye ku gitsina ryiyongera, hagakazwa n'ingamba zo kurirwanya. Abana bifuje ko hakongerwa ubufasha butangwa nutritional support n'imibereho myiza, cyane cyane ku bana babana na virusi itera sida baturuka mu miryango. Abana bifuje ko abana bambaye iniforume bakoroherezwa guhabwa serivisi z'ubuvuzi mu buryo bwihuse. Abana kandi bifuje ko ababyeyi batwite bakomeza gukangurirwa kwipimisha virusi itera sida hakiri kare no kubyarira kwa muganga, hagamijwe guha abana ngo batandura virusi itera sida. Abana kandi bifuje ko hakwigwa uburyo bwo gukurikirana by'umwihariko abana batwita cyangwa se babyara bakiri bato. Mu gice cya kane ari nacyo cya nyuma cy'ibyifuzo by'abana ni ikijyanye n'itangazamakuru. abana bifuje ko hashyirwa mu itangazamakuru, hashyirwamo ubwo bavugaga nko mu mateleviziyo, amaradiyo, ibinyamakuru cyangwa se kuri interinete, hashyirwaho ibiganiro bihoraho bikangurira abana kwirinda virusi itera sida, kwipimisha no kwivuza virusi itera sida, hibandwa cyane ku bana. Murakoze cyane kuba mwateze amatwi nk'abana cyane.
Murakoze Aline, Excellency, dear participants. It's my pleasure to present recommendations from this 3 days research conference. And these recommendations are going to respond to some of the questions that the children just put in front of us. In this conference, we got new information from research conducted by different people in Rwanda and outside. But it was also an opportunity to launch the World AIDS Day campaign with a focus on the role of media and the early treatment to reduce AIDS-related mortality. And this campaign is going to continue in 2015. We had also opportunity to discuss children issues related to HIV, using evidence to save lives. A few information that were new discussed in this conference. I will start with HIV prevalence. The data we're using come from 2010 demographic and health survey, 5%. A new study conducted last year, results presented this conference, found the same prevalence, 3%. There's no change from the last 4 years. The HIV epidemic is controlled at this level. Discovered also the comprehensive knowledge among youth, especially girls, is low, which is an issue that researchers discussed and need to address in a more specific and quick way. But also the opportunity to receive very good data that give out life expectancy of people who are HIV positive on antiretroviral treatment. This is a new data we had in this conference from research conducted by collaborative efforts of researchers in Rwanda and outside. We found that someone who is HIV positive and is 15 years old on antiretroviral treatment is expecting to live 35 more years in his life or her life. Another example in this study shows that someone who is 40 years old is expected to live 30 more years in his or her life, meaning that he is expecting to live up to the 70s. It is a fantastic news that antiretroviral treatment is working. Another important study that was revealed in this conference was that antiretroviral treatment are not helping those who are HIV positive. They are also helping the general population. The study revealed that by putting more people on antiretroviral who are in need, the impact on general population is positive. Other data shared in this conference, Excellency, dear participants, is that the transmission from mother to child of HIV has declined over years. And the current results that was shared here is that we are at 1.8%. It's not yet at the level we wish, but we are making good progress. We also heard from different research presented here, international and national presenters, that adolescent and HIV is a big issue, not only in Rwanda, but also in other countries. And we need to develop strategies that follow this group, because the same group that is going to be in the MTCT, the children we are protecting, the few who are getting infected are becoming adolescent tomorrow, so we need to help them enjoy their life. We also discussed the issue of HIV and key population, especially sex workers. Found that they are affected and infected, and they are also transmitting or being an easy channel for HIV transmission to other populations. We discovered through this conference that there is a low condom use among men having sex with men, and also an issue of multiple partnership as we discussed. Discuss health system investment as a basis to strengthen HIV program, but also the health in general. From different presenters, we found that the government of Rwanda is continuously improving. It has commended Rwanda ownership, leadership, and effective funding allocation and accountability. This discussion took part of this on HIV funding amongst the health system, but not capable of supporting the HIV program with this declining funding. We also discussed the issue of low facility costs for HIV patients at enrollment, which increase as we keep more people in treatment, inefficiencies, and resource utilization. Discuss also health innovations in transition from HIV reporting to electronic systems that may help to strengthen our evidence systems. Also discuss accreditation, quality improvement strategies, and health information tools to gains today and tomorrow. Excellency, we discuss issues but on recommendations and solutions. On the issue of males' slow adherence to treatment, the issue of males has been discussed across different tracks in this conference, and we recommended actual researchers are going to work more in developing interventions focusing on male HIV positive and how we can help them both in prevention, treatment, and supporting other programs. On the issue of high rate of loss to follow between HIV testing and enrollment, where we found that near half of people we test are not linked to care immediately. We committed to strengthen our monitoring PMCT clients for viral suppression up to 18 months, linked between health testing to care and treatment, but also help people to continue getting treatment and easy treatment along their life on this treatment. On the issue of community interventions, which is not well effective for care of HIV positives, we recommend to review policies to enable community healthcare workers to support HIV positive clients. On the issue of lack of sufficient information targeting adolescents and youth, we recommended to strengthen reporting of data disaggregated by age so that we don't confuse children, adolescents, and adults in our programs and interventions. Another issue, Excellency, the potential of HIV among adolescent girls compared to adolescent boys. The strategies that's recommended to prevention of HIV prevention among adolescents, especially girls. There's also an issue of new infections from key population, which is going through to the general population in a way or another. We recommended to develop a holistic approach in this aspect, including biomedical, social, economic strategies to address this issue of infections continues to increase in our population. Again, the same. We recommended to target this group by condom use availability and also implementing in different aspects and approaches. On the issue of decline of external funding to HIV programs, we recommended to develop a national HIV sustainability plan, and it should be done quickly because the decline is not waiting, it continues. We also recommended to continue advocacy at international level with partners, considering HIV is not just a virus, it's a human rights issue that should approach in that angle. We recommend also to work on investments, innovations, and also make more. We recommended to work more on strategies to empower young mothers to be strengthened. There are efforts already in place. We recommend to do more so that this is no longer an issue in the next meeting. Excellency, dear participants, we have discussed a lot of science and data, but briefly, this is what we captured as a take-home message to work more on interventions. Thank you very much.
And
throughout the past years of the fight against HIV/AIDS. There's been a good partnership to rally all together to fight HIV. At this moment, it's my pleasure to introduce the art and drama aspect of the fight against HIV by inviting Mashirika Group to come and perform with the audience. Thank you very much.
iwacu agacuki inshuro gicira bucura bwacu ubwo mukecuru nawe arimo gucura murabike mpange mve mu gahe murabike mpange bya gihanga si uguhanga ndanacuranga mwaraga neza umurya w'intanga nganzo nganje ngambira ngambe ingabire ingabire disi ganze nseruka nsobetse inganje y'agahinda gahinda mu mutima bakambuza gutanga isura igicazi cy'igicaza mu gacacu nibuka cyane ngacorongoza iki cyiza ndashaka ivo n'imvano yacyo nikigira umuti nta rukingo hinga nzibarize muganga.
Look to this day, for 'tis life, the very life of life. For yesterday is but a dream, and tomorrow is only a vision. But today well lived makes every yesterday a dream of happiness, and every tomorrow of hope. Clothe yourself with kindness, for every good word could bring a smile.
imetero kirabahuta kikabasambira kibasanga kibasonga umusonga kibasiga gusinda ubusenga ni icyiza kitugize inshinge ishema n'isheje rirabayobora inkoni y'icyizere murayitore hanze niba atunze maze bahe gutuza kugeza ndaruzi indoto niyo foto ukiri muto utera itoto nta na hato tuguha akato nta na hato tuguhata itetero uteye ubwuzu
Arise! Tonight my heart speaks, for it is what it is, clouded with dark shadows. Care and your support are my treasure, for I am of great value. See me with your eyes of love and dignity, for we of this great humanity.
kwirinda biruta kwivuza itabona icyuho ikaca icyanzu tugire icyusa cyuje ubwuzu inyana n'inyambo nta mushozi iyo mu mashuri dushikame shenge twoye gushoka imishinga idashinga hato tudashoka ishavu iki cyiza izi mishwanga ndashwara dore amasaha dusize tuyaruzi maze mureke duhuse twanzure twanzuranye duce hirya tureke kutweza tugaruke inganzo itaratuganza iki cyiza tukirwanye maze tugana heza.
Look to this day, for 'tis life, the light of life. For yesterday is but a dream, and tomorrow is only a vision. But today well lived makes every yesterday a dream of happiness, and every tomorrow of hope. Clothe yourself with kindness, for every word could bring a smile.
a round of applause to Mashirika Group. As I said earlier, they are all part of the big family. Naturally, we should be doing some supervision someday. Your Excellency, allow me at this moment to invite Honorable Minister of Health to the podium. Minister.
Your Excellency, distinguished guests, mine is very simple and quite complicated. I'm tasked to invite a great lady. A lady, a great lady. A lady who, beside all her tasks, her family, have dedicated her life to the welfare of the most vulnerable. And who have, by the way, been honored by a Christian university with a PhD in social justice for women HIV positive. Your Excellency, I'm very humbled to ask you to come and give your remark at this closure ceremony of the 2014 International Conference for HIV and Research. Thank you.
Thank you, Dr. Agnes. Honorable ministers, representatives of international organizations, the keynote speakers, dear children, distinguished delegates, with HIV and AIDS, good afternoon. From the recommendations from Aline and Dr. Salah, it was very clear that the last 72 hours were really well spent. By exchanging experiences and evidence, we are better able to continue the collective struggle against the scourge of HIV and AIDS. We are delighted to have hosted this year's International HIV Research and Pediatric Conference, and it's an honor for me to share a few reflections with you today. I want to appreciate the daunting task researchers have. Occasional, sudden, cannot mask the fact that your work is, by nature, painstaking and slow. Yet, perseverance is the only sure way forward. Even though we've not mastered the virus mutations, we have indeed made important progress in treating it and preventing its transmission. Working together, scientists and public health institutions have saved millions of lives and given new hopes to millions more. Excuse me, I have a call. I'll spare you too many statistics. I'm sure those who spoke before me must have given you enough of them. And I'm sure you probably know the numbers better than me. Allow me to share a little bit about the journey we have taken to respond to HIV and the important points it has brought into focus. We know that our continent is affected by HIV, representing more than 90% of the worldwide HIV burden. The HIV rates are aggravated by conflicts, socioeconomic inequality, as well as gender vulnerability, sexual violence, and migration. We in Africa need to get the science right, which means a clear focus on research and development, but also to integrate scientific results into our national health. Funding levels for treatment programs have decreased. We heard this many times, which calls to sustain the gains we have made. But the good news is that we have learned valuable lessons about the nature of HIV infection. Even more important is that we put these discoveries to use to save lives. But let's also take a moment to recall that our work speaks to a larger context. The challenge of HIV forces us all to stretch the boundaries of our imaginations beyond what we have thought possible. This is a good thing by any measure, but it's a spirit that we can also bring to bear on the many other urgent problems that confront us as a global community. And one of the important things we have seen is that HIV cannot be managed effectively with a broken health system. Therefore, the pandemic has shown us the broader importance of making our health systems work. Healthcare deals directly with human life in its most fragile moments, and it simply has to function. Investments in HIV and AIDS treatment and prevention have afforded us the opportunity to improve our system more generally, compounding the return on investment that have been made. One of the approaches that we found essential here in Rwanda is community engagement and empowerment. We have 45,000 community health workers nationwide who work on a volunteer basis to educate the community about HIV prevention and general health issues. A familiar and trusted presence at the local level. They help improve access to services and information to underserved populations. Ladies and gentlemen, as you may know, Rwanda emerged from genocide 20 years ago. This left the nation in total collapse. There were thousands of injuries to treat, and rape and HIV had been used as weapons of war. Yet our health system, like institutions, had ceased to exist. This left us with no clear. Much like a scientist or a researcher in a lab, our leadership explored a number of procedures to try and stitch together the torn national fabric. Through hard work, a common vision, and a commitment to national unity and reconciliation, our nation has moved from an emergency to a period of stabilization. Now we are working to consolidate our gains and further expand our horizons and ambitions for the well-being of our people. We started out using unconventional ways, truly experimenting with what we thought might deliver results for Rwandans. We set a bold vision, measurable development targets, with leaders at once. Every year performance is evaluated against those targets, and there are consequences if the targets are not met. This keeps our leaders on toes. We like it. It keeps the leaders accountable and improves outcomes for citizens. In other words, our policies and implementations are informed by evidence. While we can be proud of the gains that have been made, challenges still remain. Otherwise, we would not have needed to spend all these last 3 days. These challenges in the fight against HIV and AIDS should not be our stopover, but should rather be our step over. Gatherings like these demonstrate the kind of international solidarity required to make progress in fighting this pandemic. HIV and AIDS have brought the world together to solve a problem as no other global health issue has ever done. This shows how, even in terrible tragedy, the seeds of renewal and progress are always there to be found if we choose to look for them. Distinguished delegates, as I end my remarks, I wish to urge those responsible for implementation to take the knowledge from these brilliant minds and use it to make a difference. Every step, every breakthrough, a renewal of hope for people living with HIV, and a chance for them to live with the dignity they deserve. I salute their bravery and strength. Our children both challenge and inspire us to work even harder towards the next discovery. And little ones, we have heard your voices. Make sure yours is an HIV-free generation. I now declare the 2014 International HIV Research Conference closed. I thank you.
Thank you very much, Your Excellency. It is now my pleasure to announce the time for the group forum. We will be having 2 pictures taken. The first one, I'll invite again the high table to come, the children coming from all the districts. The first group forum. for the next picture, we'll invite Mr. Patrick Sibon, Dr. Nathan Ford, Mr. Chuck Fields, the three different conference co-chairs, and the Senator Silver. Mr. Fields. Thank you very much, Excellency. Once again, we would like to thank Her Excellency the First Lady for honoring us with her presence to this closing ceremony. And you all have good evening. It's a great time to network, exchange business cards, and promise to come back to Rwanda very soon. Thank you, everyone.
You've done well.
Listen, jealous. Nafata kama agri ya dada mwani mpya. Ndio kulisema sana ni ngambi.
Nice job, my friend. Nice job. She says she wants to make you feel like touche. Work those fingers, nigga. Work those fingers.
Louisa. My brother, how are you? This man, nice.
Nice.
Thank God we finished. We did well. We did well.
We managed.
We did well.
Even 50%.
We did well. I said we did well.
Yeah.
We did well.
I was following the piece. Now I get you.
But the conference.
Yeah.
You just set your camera.
Yeah. Stable, not cinema. Yes.
You just see one person.
Yes.
Who is paying attention.
Hey.
You stay there. Wait.
Stay.
When
Wait.
you stay, you say.
Yes.
You have camera. Five.
We don't go on you. Yeah.
So you
don't go on you.
The
more we walk the ground, the better.
5 minutes. Just show.
Yeah.
Did you see what these guys were doing from RBC? When they set the camera, they sit down. There was no need for you to be moving. It's a conference. Right? If it's something like a drama, like when they're performing and you guys are moving around, yes, you know, because you're following them. But conference, you want the camera to stay, you want them to get the message. Oh, and you're not looking for. But well done, man. Well done, sir. Thank you very much, sir. Awesome, well done, sir. Louisa, this way.
So it's a blessing for me for this conference.
This way. Just come this way, it's easier. Why don't you just come this way? Ya hili ya kutoka kwa.
Witonde wanye n'uri hejuru uwo uri ku kintu cy'umweru hari microphone iri hano ra? Noneho uyu nawe n'uwanjye parike yo hejuru
iyindi
iyi ngiyi
ini yawe
iyi nguyu yawe ubitse yawe ubitse flashe yego
yaretse gushyirire we yarakiri gushyira hamwe byose
Do you like to